I would like to continue with the next speaker, and it is about distal thrombectomy in stroke. I'm very pleased to introduce Aleksandra Aracki Trenkic, and we are very pleased to hear your presentation.
Thank you for your kind introduction. First of all, I would like to thank the organizers for the invitation. It's my pleasure to be here again, and I will try to explain the essence of distal thrombectomies. So nowadays, endovascular treatment has been increasingly considered the primary treatment for distal occlusions, and this type of treatment is more challenging due to the smaller caliber of the arteries, more distal location, and long and more tortuous course of affected vessel. Therefore, there is a higher risk of complications such as dissections, perforations, and consequent vasospasm. So, distal occlusions account for 25 to 40% of all strokes. They can occur de novo, and primarily as de novo, or secondary due to the fragmentation and abilization during the EVT for the proximal large vessel occlusion. And to select the appropriate devices, it is necessary to first define the anatomy borders of the arteries and the artery diameters. So there is a controversy regarding the grouping of some of the arteries, like the segmentation of MCA artery, especially the M2 branches, and also A1 and P1, which has varied. So first of all, we need to recognize the normal anatomy, especially the type of M2 arteries, whether it is dominant, codominant, or non-dominant, as we can see in this diagram. And what about the studies? The first studies for endovascular treatment far away in 2013 were negative. Then beginning from 2015, multiple trials have shown the benefit of thrombectomy in early large vessel occlusions, followed by extending trials in 2018 and large core trials in 2023. But how about the distal occlusions? Can we infer to distal occlusions the positive results on trials on proximal large vessel occlusion? To be honest, I think no, but we will see during the presentation. So, in order to achieve successful recanalization, it is necessary to estimate the length and the size of the stent. And the new trials have shown that the long stent retrievers led to a higher rate of subarachnoid hemorrhage and longer procedure time. And short stent retrievers have demonstrated a higher first pass successful reperfusion. So these results are completely opposite to the previous trials indicated a better result using longer stent retrievers. And why is it happened is that the long stent retrievers provide a longer contact surface on the vasculature, and in distal vessels, which are tortuous and shape angled, there is a high possibility of over-straightening and the placement of the whole artery tree during the extraction of thrombus using a long stent retriever. On the other side, stent size definitely influence stent properties, meaning radial force, flexibility, and availability. So stent with a large radial force is more suitable for the proximal vessels, and the stent with a less radial force, smaller size, and the more flexible stent is more suitable for the tortuous and distal vessels. So the treatment of distal occlusions has been significantly improved with the implementation of a smaller stent retrievers, with a longer push wire, and with increased maneuverability. And here we can see a list of different stent retrievers, and the availability of them depends on the region of practice, of course. But in my opinion, a notable stent retriever is a Tiger 13, which enables variable control, expansion manipulated mechanically by the operator through a core wire according to the desirable diameter. This stent is compatible with the 0.13 micro and thus can approach very distally. Also with this stent, we can prevent the overstraightening of the artery by the relaxing stent during the extraction, and also we can better capture the thrombus due to the possibility of the overexpansion of the stent. Here is the list of the different microcatheters, and of course low-profile distal aspiration catheters are inevitable in the treatment of distal occlusions. These catheters can be determined after confirming the target vessel size to overcome the oversizing with the 4 max or insufficient clot engagement with the 3 max. So the most used low-profile distal access catheters are 3 max and 4 max, and of course in the last year also the RED 43. And the caution of course must be taken regarding the technique where the intermediate catheter needs to be in contact with the thrombus, not to leave the empty space for the collapse of artery and then to have hemorrhage as a complication. For the techniques and devices, preference vary based on the site of occlusion, the region of the practice, and of course the local experience. So the stent retrievers alone are more desirable in straight vessels as in 8-3 occlusions, and combined approach is used in more proximal distal occlusions. So what are the common issues regarding the distal occlusions? First of all, if you use only the stent retrievers, there is a higher rate of possible subarachnoid hemorrhage as a consequence of increased shearing of the arteries and displacement of the artery 3. So the purpose of a mini pinning technique is to try to avoid pulling and straightening of the arteries. But when we're using a mini pinning technique, there is a problem with the limited length, because most of the conventional microcatheters are shorter than a low-profile aspiration catheters, and they could not protrude over them. So the blind exchange mini-pinny technique was created to overcome these limitations. So with this technique, we can use any mini stent retriever regardless of the length of the microcatheter or of the low-profile distal access catheter. And given the stiffness of the stent retriever push wire and that the stent is anchored across the occlusion vessel site, we can do the maneuver of changing maneuver, or we can navigate the low-profile aspiration catheter without a risk of migration or lose the push wire. But again, what is about the potential risk of a vessel injury as a consequence of the applying force during this maneuver? Modification of this technique has been made by the team from Basel in order to reduce the risk during the exchange maneuver by using extension wire on the stent retriever. So the pressed light is the stent retriever, which can be used with extension wire, and then there is a working length of 350 centimeters, so it is completely enough to perform the exchange maneuver. Also, another technique has been made by the team from Basel, and the name of this technique is Quattro technique. This is a modified safe technique, and the use in this technique, the use of a longer microcatheter of 167 centimeters, low-profile distal aspiration catheters enable safe access to the thrombus. Also, I should mention a semi-deployed stent retriever technique where we use the partially deployed stent retriever just to achieve adequate working length of the stent to engage the thrombus with avoiding unnecessary length of the open stent across the sharp angles of the vessel. Of course, the aspiration techniques play also important role. We can use the DAP technique or for more distal vessels, for more fragile vessels as a superior cerebellar artery. We can use a micro-DAP technique with a headway 27 microcatheter, which is completely suitable for the distal aspiration. techniques. And in conclusion, when we are choosing the devices, it is important, just to repeat once more, it is important not to oversize or undersize the distal aspiration catheter. Of course, it is important to select appropriate size and length of the stent. And in order to prevent straightening of the arteries, we should choose the appropriate technique according to the patient's anatomy. And what I think that here it's most important is that there were high expectations regarding the ongoing studies, but the caution was advised as the most of the non-randomized studies have shown negative results. And the results for the three large trials were presented at ISC in Los Angeles month ago, and the investigators concluded that endovascular treatment did not provide additional benefits in reducing disability or mortality compared to standard medical therapy in distal occlusions. And the discount trial was stopped early due to safety concerns and signs of futility. But this was due to the selection of the patient and the difference between the studies, because the discount study include only the patients with the distal and no with the proximal M2 occlusions. So as main conclusion, endovascular treatment cannot be for the distal occlusions, cannot yet be recommended as a standard treatment for distal occlusions. However, it remains a viable option in special cases as no increased risk have been identified. And if you want to learn more about the distal occlusions, please register for the webinar and learn from the experts from these topics. So thank you for your attention.
Thank you very much for this great presentation. Are there any questions from the audience? Otherwise, I'd have a question for you. So if you're past the Sylvian Fisher point, what is your choice? Aspiration first or stent reaver first? Do we presume that with a stent reaver there may be more tears causing subarachnoid hemorrhage, although it doesn't seem to be related to outcome in the end?
From my experience, I'm always starting just with the aspiration, and I have a really good first pass results. But the studies shown that the better results are obtained with the combined techniques, but we need more time and a lot of devices. So first of all, we need to have all these devices, and we need to know exactly the length, the size, because if we make a mistake, then if we need to go through the process from the beginning, we will lose a lot of time.
I do exactly the same as you do. Can I just ask what you would do?
Yeah, I mean, we would try to do either technique or the other. We have been participating in Escape Mivo, and I congratulate you on your presentation. I'm really happy that you only spoiled the conclusions, but not all the details. So I will have my presentation actually on the detailed explanation of why these trials failed. And I completely agree with you that my initial approach would be also based on the Escape experience, probably in aspiration and combined technique is the next. In the Escape we use the stent retriever-based approach, and we do see that quite a few subarachnoid hemorrhages occurred due to the stretching of the vessel that you have so well detailed in your presentation.
Thank you.
I would ask one more question, and that is probably not so much in the Mivo, but how much do you think in stent retrieval the size of the microcatheter matters when you have to go for the lesion in terms of creating distal emboli? So would you choose the stent retriever device where the microcatheter has the smallest diameter, or what would be, again, your choice? Do you think it matters what the size of the microcatheter is when you initially go for the thrombus?
I think that the size of the microcatheter definitely counts a lot. So my opinion is always to try. There are a lot of small stents in the market, but for my opinion, I have the best results using a Tiger 13 due to possibility to overexpand or to relax the stent during the extraction. So the Headway Duo as one of the smallest micro with the smallest lumen for me is the best option. So if we have the low profile microcatheter, there is a potential risk for the damage of the vessel is lower. Thank you.
I think it's also an important point to have the microcatheter that really well works together with the stent retriever, because one thing is that if you have an O21 or 27, it does have an importance when you're crossing, but also when you try to deploy your stent retriever, if you're choosing a stent retriever in distal location, having more control is also very important. So if you're using two devices that are not really matching, for example, it's very difficult to push it out, then it might jump, and then you may cause perforation. So I think it's also important that the two devices go well together, and it's not stucking, and it's not difficult to deploy. So so it's always the two together, and in that sense, yeah, it's reasonable to use the Tiger, which you can adjust the diameter.
So there are a lot of questions now after all these studies, but a lot of devices in such a small arteries, maybe it's not a good idea. Maybe just if we use just aspiration, we will obtain the better results in the end. Thank you.
I would like to... Any questions from the audience yet?